Hello friends, I am Dr. Harsh Mathur from Om Netralay, Varanasi, India, and today I will be discussing what problems I had to face and what all I had to do. The patient was uncooperative, so the moment I went about going to make a side port, the patient moved his head. Second attempt, the same problem, not only the eyes but also the head. Okay, let's try one more time. I had to place some more Paracaine eye drops, but again the patient was not cooperative, was very anxious. So let's switch to subtenance mode. 1 ml of lignocaine is injected in the inferonasal quadrant with a 26 gauge needle and wait for 30 seconds, and now as you can see the patient is quite comfortable, and we proceed with the surgery. So the surprises don't end here. Once we remove the nucleus, we again got a surprise, so stay tuned. By now T plus ultra has been injected to keep the pupil dilated. The chamber is maintained and we will be proceeding with a 3-planar main incision. 2.8 mm keratome is used and a tunnel is fashioned. Approximately 3 clock hours away, a side port is made. The surgery has been sped up so that I can show you the whole surgery. A 5.5 mm mark has been made, which will help me guide the rhexis. A 26 gauge bent cystitome is then used to fashion the rhexis all around. You can see the dye has done its job. We can visualize the anterior capsule nicely over the background of the white cataract. So the trick is to keep the dye in the anterior chamber for at least 20 seconds so that the anterior capsule takes a good stain. A bit of hydrodissection has been done. Now is the time to rotate the nucleus. So now you can see I am having a bit of problem taking the probe inside. So just take the dialer, put up counter traction, and then that will ease out. Now the bevel is turned up. We'll be doing a stop and chop maneuver. At first, though this is a young patient, so I was expecting a bit softer nucleus. Now see, I did not make a trench deep enough, so the nucleus did not crack, but then I increased the depth and then the nucleus divided into 2 parts easily. Now the chopping is done. 1 heminucleus has been chopped and the second heminucleus is also chopped. Now is the time to emulsify the nucleus. Further sub-chop is being done. Now as you all can see, I am having a bit of trouble keeping the eye in the primary position. The eye is turning medially despite my best efforts, and the patient is also not helping much. Always keep the dialer and the probe in a triangular position so that the nucleus do not chatter and hit the endothelium. And in the last piece, lower the parameters, keep the dialer in the safe position, protecting the capsule, posterior capsule, and we have managed the nucleus. But then this is not it. You can see so many cells are sticking over the posterior capsule. It's just like when you remove a fevi stick from a surface. The surface has all those sticky parts remaining. Now I'm trying to polish the capsule, but these cells are refusing to come out. Several attempts were made with Simcoe cannula to clean the bag. But these cells were redundant and did not come out. So my next plan was to use a visco cannula, keep injecting visco and gently scrub the cells from the posterior capsule. Though this video has been sped up, this took me almost 5 to 7 minutes. With a lot of effort, I was able to clean the visual axis. So when you are stuck in such situations, go slow, keep all the possibilities open. Not every case is the same, and not every time what you expect comes out. So I never expected this kind of cells in these redundant cells in this case. Now while I am polishing, I can see the folds in the posterior capsule. So now I am planning to put the IOL first. A hydrophobic intraocular lens is placed. The leading haptic goes in the bag and the trailing haptic is then dialed in. So just doing a case is not it. We are still learning. I consider myself a beginner surgeon, beginner phaco surgeon. So then after recording this video, I went to the stalwarts of ophthalmology, Dr. Pradeep Mohanta, Dr. Neto Rositelli, Dr. Sunil Thangraj and Dr. Saurabh Patwardhan for their expert view. How I could have done this case better, what were the other options that I could have tried, what was their insight, what would they have done. So always keep learning, take help from your seniors, your teachers. They'll guide you to the best of their ability always. So that's it. Finally I was able to clear most of the cells. A bit of moxifloxacin is then injected and the wounds are hydrated. So the take home message is, keep your mind open, discuss your surgeries with your friends, colleagues and teachers, and keep growing and do the best you can for the patient at the moment. And that's it.